Hello again, everyone, and welcome to Unit 5. This week we're going to talk just about one disease, diabetes mellitus, a homeostatic disorder of glucose metabolism. And why we're going to spend a whole week on diabetes, I think as we move through this presentation, you'll see why the tremendous prevalence of diabetes within the U.S. and diabetes being such a huge risk factor for vascular disease. In fact, as we'll go through this unit, you'll see me often refer to diabetes mellitus as being a vascular disease. We haven't yet covered atherosclerosis. We'll get to that in the cardiovascular units, but we'll be introducing that a lot in this unit and looking at what is it about hyperglycemia, elevated blood sugar, that leads to this increased risk of vascular pathologies. So the pancreas is located in the abdominal cavity, kind of centrally located in the upper regions. We refer to that as epigastric, sits below the liver, behind the stomach. There are two roles of the pancreas. There's the exocrine function. The exocrine role of the pancreas is to produce digestive juices and digestive enzymes, release those juices and enzymes into a large duct, which then opens into the small bowel, and that's going to then aid in the chemical digestion of food. The endocrine pancreas releases hormones into the bloodstream, and then those hormones have their effect on other organs in the body. And we will be talking about two primary hormones, insulin and glucagon, and then we'll also be talking about another hormone which has its effect on the pancreas, the incretins. When you look at the CT scan, the pancreas is highlighted by the yellow arrow, and if you look in the center of that organ, you can actually see that large pancreatic duct. The red dot is the stomach, green dot is the gallbladder, blue dot is the liver. Two yellow dots are the bilateral kidneys, and then you can see the vertebral column at the orange dot. So looking at the top, you see a glucose molecule. That glucose molecule is very polar, meaning that it's not soluble in fat. Cell membranes are rich in phospholipid fat, so it's very difficult for that glucose molecule to get out of the blood and into cells. Most cells require an insulin mechanism to move glucose into the cell. We'll look at that a little bit more closely. The pancreas is responsible for insulin secretion. The pancreas is always putting out a small amount of insulin continuously. That's considered the basal amount of insulin. And then every time we ingest carbohydrate and increase our blood glucose levels, additional insulin is released in bolus fashion. And it is this interaction between basal and bolus release of insulin from the pancreas which maintains blood glucose levels at a normal, maintains blood glucose levels in a normal range or at set homeostatic points. So diabetes mellitus is a defect of glucose metabolism primarily due to defects with the insulin system. Either the individual is not synthesizing and secreting insulin, or the action of insulin itself is faulty. Diabetes mellitus is also associated with abnormalities in fat and protein metabolism in addition to carbohydrate metabolism. The primary manifestation of diabetes mellitus is elevated blood glucose levels or hyperglycemia. And then we say, well, why are we so worried about elevated blood sugar? The problem with elevated blood sugar is elevated blood sugar is going to have an adverse effect on the vasculature. It can affect small blood vessels, it can affect large blood vessels, and it can have direct effect on nerves as well. So diabetes mellitus is in fact a vascular pathology, and we're going to look a little bit at the biochemistry in terms of why elevated blood glucose damages blood vessels and nerves. What we're looking at here is atherosclerotic plaque. Now let's look at the top photo first. This is a histologic section of an artery. The middle of the artery should be wide open. That's the lumen. That's where blood is moving through. The most inner lining is the tunica intima, also referred to as the endothelium. Immediately below that is the tunica media, which is primarily made of smooth muscle, making that artery or vessel very elastic, able to expand and constrict. The constriction and the relaxation of that smooth muscle either closes down the lumen of that artery or opens it up. And the most outer part of the blood vessel is the tunica adventitia, connective tissue holding it all together. Now, if you look at the two pictures at the bottom, you can see that the lumens are being occluded. What we're looking at there in two different types of sections and two different types of staining is the atherosclerotic plaque. The atherosclerotic plaque is in no way homogeneous. The atherosclerotic plaque is made up of a number of different substances which is accumulating in the wall of that blood vessel. And the more accumulation of atherosclerotic plaque, the more that blood vessel occludes. Diabetes mellitus produces products called advanced glycation end products, abbreviated AGEs, and these AGEs play a huge role in initiating and perpetuating that atherosclerotic plaque. Now, we haven't covered atherosclerosis yet in this course. We will cover it in much more detail in the cardiovascular units. But right now, think to yourself, other than these AGEs, which I just mentioned, what else accumulates in that plaque? You should be able to come up with a couple of different things which are accumulating in that atherosclerotic plaque, blocking that blood vessel. Diabetes mellitus affects both the small blood vessels and the large blood vessels. And all the complications that you see due to diabetes mellitus, coronary artery disease, renal disease, foot ulcers, retinal disease, plus more, this is all due to enhanced accumulation of that atherosclerotic plaque in the large and small blood vessels. Once that plaque accumulates, once that narrow lumens, once that arteriole loses compliance and is not able to dilate and increase blood flow, the effects on the end organ are due to ischemia. You're just not getting adequate blood flow to the organ. When you don't get adequate blood flow into the organ, then the tissue starts to die. So again, can't emphasize that enough. Diabetes mellitus is a vascular disease affecting both large and small blood vessels. What is the burden of diabetes mellitus in the United States? According to the CDC, their most recent epidemiologic data from 2017, they state that just under 10% of the population has diabetes mellitus. If you look at the bottom, you can see that diabetes mellitus increases with increasing age. About 4% of individuals between the ages of 18 and 44 have it, 17% between 45 to 64, and about 25% over the age of 65. So the older you get, the greater is the chance of having diabetes. Here we can see the distribution of diabetes between male and female genders by different ethnicities as well. And you can see that Native American or American Indian, non-Hispanic, black, and black account for the races and the ethnicities which have the highest burden of diabetes. We'll talk more about pediatric diabetes under the age of 18 as we move on in this unit. Have you heard about the Bible Belt? Have you also heard about the diabetes belt? This is the prevalence of diabetes across the United States. This was in 2013. Hasn't changed much in the subsequent years. The highest burden of diabetes appears to be in the Southeast United States. But you can see that there are high pockets of diabetes throughout the continent. The darker the county, the higher is the incidence, and they're showing you the rate of diabetes per 1,000 individuals. Now I have a theory on this. Ready? How many of you have traveled or spent any time in the Southeast United States? I've spent a lot of time there. I have a number of family down there, and I love to get down there. And one of the things that I like to do down there, and that they love to do in the Southeast United States, is drink something called sweet tea. You ever had this stuff? It's like liquid crack, right? Liquid crack cocaine. It's so good, but it's so loaded with sugar. Bojangles restaurant, a common restaurant in the Southeast United States, and here you can see the distributions of Bojangles restaurants along the Southeast and Atlantic coast US, produces a sweet tea which has 420 calories with 104 grams of sugar. That's a lot of sugar. My own theory on why there's such prevalence of diabetes in the Southeast United States is due to the consumption of sweet tea. Now let's look at Wisconsin. This is from the Department of Family Health Services, state of Wisconsin. And you can see the percent diabetes by county. The darker the county, the greater the prevalence. So you can see some areas around Wisconsin where it's fairly prevalent. Seems to have a much higher prevalence in the northern part of the state. Remember, northern part of the state, there are a lot of Native American, American Indians. And remember, that is one of the most highest affected races with respect to diabetes. Now, I know in Wisconsin, we don't have Bojangles restaurants and we don't have sweet tea to the prevalence as they do in the Southeast United States, but we do have this. Hold on. Yeah, we have custard, right? So there's the distribution of Culver's. Culver's is primarily a Midwest phenomenon, and they make those awesome concrete mixers. This is a small size concrete mixer, 700 calories, 74 grams of sugar. So why am I talking about sweet tea and why am I talking about Culver's concrete mixers? We're going to talk about diet and consumption of carbohydrate and how that plays a role in the development of type 2 diabetes and how excessive consumption of carbohydrate will make worse any form of diabetes. Again, from the CDC, some of their more 2017, some of their more recent epidemiology, coming close to 30 million people in the US with diabetes. It's about 1 in every 11. About 1 in 4 of those individuals who have it aren't aware that they have it. About 1 in 3 individuals in the US have a condition known as pre-diabetes, and we'll talk about that. And you can see individuals with pre-diabetes have a pretty high chance of moving into type 2 diabetes within 5 years. And this is providing that they do not lose weight and providing that they do not partake in moderate physical activity. We're going to see the importance of diet, weight, and exercise, and not only preventing type 2 diabetes, but also being able to improve and minimize the damage being done by type 2 diabetes. Okay, cardiovascular disease is the leading cause of death in the United States. Cardiovascular disease, both heart attack and stroke, is due to atherosclerosis. This is considered to be a macrovascular complication, big vessel complication. Atherosclerosis in the carotid arteries, in the cerebral arteries in the brain, in the great vessels, in the coronary arteries. You can see that atherosclerotic plaque in the middle there, occluding that artery. Complete occlusion of those arteries can lead to heart attack, can lead to stroke. Again, the most common cause of death in the US, and a primary and extremely important risk factor in cardiovascular disease is diabetes mellitus. Blood glucose levels are maintained at a normal range between 60 to 110 milligrams per deciliter. There are 2 primary hormones which are regulating blood glucose levels. Both of these hormones come from the endocrine pancreas. Glucagon comes from the alpha cells. Insulin comes from the beta cells. Insulin lowers blood glucose levels. Glucagon raises blood glucose levels. So if you sat down and had a Culver's concrete mixer or ate a meal, ingested carbohydrate, absorbed that carbohydrate, and put that sugar into your blood, insulin is going to be released, and insulin is going to move that elevated blood sugar into the liver and other cells of the body. If you wake up in the morning and have nothing to eat, go to work, go to school, do whatever it is you're doing, and you go for a number of hours without eating, and your blood glucose levels start to fall, the pancreas is going to release glucagon. Glucagon is going to act primarily on the liver and begin the breakdown process of stored carbohydrate as glycogen, converting that into glucose and pushing that glucose out into the bloodstream, thus raising your blood sugar. So this interaction between glucagon and insulin is critical in maintaining that set homeostatic range of blood glucose levels. I'm calling it 60 to 110 milligrams per deciliter. you may see that go up to 120 milligrams per deciliter and still be considered normal. So insulin and glucagon are both hormones. They are a chemical which acts as a messenger, synthesized and released in the pancreas, released into the bloodstream, and then has its effect on other organs around the body. So it meets our definition of a hormone. Insulin and glucagon are both protein hormones. Glucagon is a single protein chain made up of 29 amino acids. Insulin is two chains linked together made up of 51 separate amino acids. You do not need to memorize the amino acid sequence of either of those two proteins unless it's something you want to do to look smart at a cocktail party or whatever. Don't memorize the amino acid sequence, but understand that these are protein hormones. Insulin is an anabolic hormone, meaning that we build things up and store energy. Glucagon is a catabolic hormone, meaning that we break energy down into substrate and then utilize that, burn that substrate for energy and ATP. Insulin is actually made in an inactive form. That inactive form is called pre-proinsulin. So this pre-proinsulin is made in the pancreas. When insulin is ready to be released into an active state, that large protein gets cleaved at two sites, and part of that protein gets released, referred to as the C-peptide. Once you cleave off that C-peptide, then you're left with then that protein essentially then forms two separate chains. That two-chain protein then is active insulin. Insulin consists of two chains, an A chain and a B chain, and they are linked together by sulfur bonds between cysteine amino acids. Take a look at table 21.7 in our textbook, and you see that there are numbers of different mechanisms of action of insulin, and those mechanisms are considered to be anabolic, energy storing. Again, about 10%, coming up on 10% of the population, of the U.S. population, has diabetes mellitus. There are a couple different types of diabetes mellitus. We are primarily going to be discussing type 1 and type 2. Type 1 diabetes is a state where an individual does not make any insulin. An autoimmune reaction has destroyed their pancreatic beta islet cells. Remember, the pancreatic beta islet cells are responsible for insulin production. These individuals make no insulin. They are therefore 100% dependent on an exogenous source of insulin for survival. This accounts for about 10% of all cases of diabetes mellitus. Most individuals with type 1 diabetes are diagnosed prior to the age of 30. In fact, the onset of type 1 diabetes in most individuals is during when they are children. Type 2 diabetes is a state of insulin resistance. You can consider type 2 diabetes as insulin is underperforming for the demand required. That can be either due to the fact that the individual is not secreting enough insulin, or what insulin they are secreting is not having adequate action on the cell. And in fact, in type 2 diabetes, both inadequate release and inadequate action both play a role in the pathology. Type 2 diabetes is most commonly diagnosed after the age of 40, but more and more young individuals are being diagnosed with type 2 diabetes. Body mass index, weight, and diet are huge risk factors for type 2 diabetes. Prediabetes is a state where the individual has elevated blood glucose levels, but they have not yet quite reached levels which are diagnostic of having diabetes mellitus. Individuals with prediabetes who do not partake in lifestyle changes have a high risk of moving into type 2 diabetes. We're not going to talk about other forms of diabetes, gestational diabetes, MODY, a genetic syndrome, mature onset diabetes of the young. We're not going to talk about pancreatic pathology, but if you lose your pancreas for whatever reason, trauma, cancer, you lose your pancreas, you lose your ability to synthesize and secrete insulin. That will also lead to a form of diabetes mellitus. But we'll spend most of our time talking about type 1 and type 2. This is a nice chart which compares type 1 and type 2. I would like you to spend some time looking at this chart, being familiar with it. Everything I just talked about in the previous slide summarizes this chart. One thing to look at is if you were to look at insulin levels, a type 1 diabetic patient should have no insulin in their blood because they can't make it. Their beta islet cells have been destroyed due to autoimmune processes. And a type 2 diabetes individual, most of those individuals are going to have detected levels of insulin. Now, late in the course of a severe type 2 diabetes, that insulin may not be, that person may not be producing any insulin. But in general, most individuals with type 2 diabetes are able to produce some insulin. They're just not producing enough for the demand. The diagnosis of diabetes mellitus is made on glucose levels and a hemoglobin A1C, and we'll talk about more what a hemoglobin A1C is as we move on. These levels of hemoglobin A1C, fasting glucose levels, and random glucose levels pertain to any form of diabetes, and specifically type 1 or type 2. If you hit these values, you have diabetes mellitus. Once you make a diagnosis of diabetes mellitus, you then want to determine what type does the individual have. So let's start off first looking at the numbers. Normal hemoglobin A1C is less than 5.6%. We all have some amount of hemoglobin A1C, even if we do not have diabetes mellitus. So normal, less than 5.6. Our fasting blood glucose levels, so what should our glucose level be without eating for 12 hours? We should be less than 100. And a random blood glucose level should be less than 120. Diabetes mellitus, an individual has diabetes mellitus if the A1C value is greater than 6.5%, if a fasting blood glucose level is greater than 126 milligrams per deciliter, or if a random blood glucose is greater than 200. If you hit those criteria, you have diabetes mellitus, and then we have to decide what type you have. These are important levels to know. I would like you to commit those levels to memory. 6.5%, 126 fasting, and 200 random as being diagnostic of diabetes mellitus. Okay, type 1, diabetes. What happens in type 1 diabetes? You are destroying the beta islet cells. It's an autoimmune response. T lymphocytes are at work and specifically destroying beta islet cells. That's the site of insulin production, so those individuals therefore stop making insulin. There definitely is some genetic susceptibility to type 1 diabetes mellitus. Some of our human leukocyte antigens or HLA antigens, if you carry certain genes within your HLA genotype, you have an increased risk of type 1 diabetes. There's 2 of them which have been known to show an increased risk of type 1 diabetes, type 1. You don't need to memorize those specific genes, but understand that some individuals are going to have a genetic predisposition. There is this role of an environmental trigger, which is often some type of viral infection. So a high-risk genetic individual suffers a viral infection, and some of the viruses known to do this: Coxsackie virus, enterovirus, rubella virus. The combination of that environmental trigger with genetic susceptibility may lead to the onset of the immune reaction. And again, that immune reaction is going to be mediated by inflammatory mediators turning on these T cells to attack self-antigens. Now, there's some stuff that you'll see on the internet that say that if you drink milk, so if you are exposed to bovine serum albumin, or if you're eating gluten cereals, you increase your risk of diabetes mellitus. I don't know that there's any real substantial literature on that. I will let you find that on your own on the internet and make up your own mind. I don't believe that the evidence is really, really strong that cow's milk and gluten cereal are causing individuals, particularly children, to have type 1 diabetes mellitus. But that's out there, and you can find that on the internet. Autoantibodies can be detected in individuals with type 1 diabetes, but the actual destruction of the pancreas is T cell mediated. If you take an individual with type 1 diabetes and you look at their blood, you can find certain autoantibodies, antibodies targeting pre-proinsulin, antibodies targeting a decarboxylase enzyme, an enzyme which is necessary in the synthesis of insulin, and antibodies targeting a zinc transporter protein referred to as ZNT8. So one way that we can differentiate an individual as having type 1 diabetes is to screen them for these autoantibodies. And if they test positive for the autoantibody, that is usually pretty good evidence that the individual has type 1 diabetes. In August of 2014, the FDA released and approved a new autoantibody test, an autoantibody test which detects this zinc T8 antibody. And now, like I said, detection of one of these antibodies, and specifically this one now, zinc T8, can be indicative of an individual who has type 1 diabetes. If you look at that beta islet cell at the top, remember the beta islet cell is creating the insulin. There's a number of proteins involved in insulin synthesis. And in individuals with type 1 diabetes, they can test positive for a number of different types of autoantibodies to components of that beta islet cell. This antibody test to the zinc transporter protein has been made into one of these simple what they call an ELISA kit, enzyme-linked immunoassay. This is something that can be done now fairly easily in an office setting. And that test, again, was approved in 2014. What is it about zinc and insulin? So insulin is actually released as a hexamer. Hex meaning 6, meaning that 6 insulin molecules are held together, and they're held together by a central zinc molecule. Once insulin is released, that hexamer breaks up into monomers. Those monomers are no longer held by zinc, and it's the monomer which is active in plasma. So it's the monomer, it's the A and the B chain together, which is binding on the insulin receptor and doing the activity. But when released, it's initially released as a hexamer, 6 of those double-chained insulin molecules held together by centralized zinc molecule. So that's the importance, that's the importance of zinc to insulin. Now, if we were going to do a quick summary on the pathogenesis of type 1 diabetes mellitus, or how does one develop type 1 diabetes mellitus, it would look something like this. You would take a genetically susceptible individual who's exposed to some type of environmental trigger, most commonly, at least documented, certain types of viral infections. That initiates an inflammatory process which starts to attack self-antigens. I've heard this term used, insulitis, as that inflammatory response targeting the beta islet cells. It's usually a slow process. Believe that it may take months to actually get to the point where the individual is symptomatic. And during that period of time where their pancreatic islet cells are being destroyed, the individual is unaware that the process is occurring. You need to lose about 80–90% of the function of your beta islet cells to start developing the clinical manifestations of diabetes mellitus. So again, as you're losing your insulin, as you're losing your beta islet cells, you're not producing insulin. Your blood sugar levels are elevating. And as your blood sugar levels elevate, common symptoms of hyperglycemia are polydipsia, constantly drinking, polyuria, constantly peeing, and that's due to the fact that you are spilling glucose in your urine, polyphagia, continually eating, losing weight, getting tired, and again, elevated blood sugars. The individual who presents under the age of 30 with these symptoms meets the diagnostic criteria of glucose levels and A1C levels, is therefore diagnosed as having diabetes mellitus. Confirmatory testing can be done, presence of autoantibodies, lack of detection of insulin in the bloodstream, and then a diagnosis of type 1 diabetes mellitus can be made. The pathogenesis of type 2 diabetes is a little bit different. Genes and environmental factors certainly play a role, and we'll get into this a little bit more as we move on. The genetically susceptible individual with the acquired risk factors, the environmental risk factors, particularly weight, diet, and physical activity, leads to two problems. Number one, insulin resistance. The action of insulin is just not as effective as it should be. and insulin deficiency. Eventually, beta islet cells will burn out in the individual, leading to less and less synthesis, production, and release of insulin. That individual then goes on to develop type 2 diabetes. Beta cell failure is being recognized more and more as an important component of type 2 diabetes. So you take an individual who develops insulin resistance. They're releasing some insulin, but their insulin is not as effective as it should be. So what do? They release more and more and more and more. And the insulin that they're releasing becomes less and less effective. Their response, their endogenous response, is to pump out more. And as those beta islet cells start working overtime and cranking out that additional ineffective insulin, over time those beta cells fail and burn out, and beta cells are eventually lost. So one of the treatments that's being looked at in terms of type 2 diabetes, and we'll look at some drugs that are known to do this, are drugs that try to save the beta cells, try to prolong the survival of the beta cells in a type 2 diabetic. In type 1 diabetes, those beta cells are gone. By the time they get diagnosed with type 1 diabetes, those beta cells are gone. But in type 2 diabetes, there's some opportunity to enhance and prolong the survival of those beta cells. So what are the risk factors? How do we get to this state of insulin resistance, which leads to type 2 diabetes? Well, number one, there are some genetics to this. If you have type 2 diabetes in your immediate family, you're going to have an increased risk. If you fall into one of these high racial ethnic groups, Black, Hispanic, Native American, Pacific, Asian, Pacific Islander, you will have an increased risk of type 2 diabetes. We know that type 2 diabetes increases. Previous slide said age 40. This one says 45. Again, once you start getting over the age of 40 and into middle age, and certainly over the age of 65, risk for type 2 diabetes increase. Body mass index and waist circumference are important. We'll take a look at that. Physical inactivity. If you have underlying hypertension, if you have underlying triglyceride disorder where your total blood triglycerides are greater than 250, if you have low high-density lipids, low HDL levels, or if during a pregnancy you developed gestational diabetes, all these increase your risk of going on to develop type 2 diabetes. I'm a big fan of the Simpsons TV show. Homer Simpson is a classic example of an individual who, if he doesn't have type 2 diabetes, is certainly on his way to developing type 2 diabetes. Overweight, sedentary lifestyle, extremely poor diet. If you're a fan of The Simpsons, you know what I'm talking about. Okay, waist circumference. Let's look at waist circumference and how that plays into increased risk of type 2 diabetes mellitus. So you know what body mass index is, right? You take an individual's height on the y-axis and you take their weight on the x-axis and you look where they intersect, and then that gives you their body mass index. And we can rate individuals as being underweight, healthy, overweight, and obese. Individuals who fall into the obesity category have the increased risk of diabetes. And actually some of these BMI charts then will rate obesity in 3 different scales, kind of mild, moderate, and severe, where extreme obesity is a body mass index over 40. Those individuals are going to have an extremely high risk of type 2 diabetes. And then some research has also shown that in addition to BMI, you can look at waist circumference. So men who have a waist circumference greater than 40 inches and women who have a waist circumference greater than 35 inches also increases their risk of type 2 diabetes. So here are two screening things that you can be doing in primary care, is not only looking at BMI, but also be looking at waist circumference. Okay, what is pre-diabetes mellitus? Pre-diabetes mellitus is a state which puts you at risk for type 2. You're carrying risk factors for type 2 diabetes, but you have yet not met the blood glucose and the hemoglobin A1C criteria. So those are the individuals who kind of fall between the normal ranges and the diagnostic criteria. So people who have fasting blood sugars between 100 and 125, individuals who have hemoglobin A1C values between 5.7 and 6.4, we can call these individuals as having pre-diabetes mellitus. Remember, A1C values greater than 6.5 and fasting glucose levels greater than 126, those are diagnostic criteria for diabetes mellitus. Pre-diabetes is you have blood glucose and A1C levels that just have not quite hit those levels yet. And it is estimated that over 80 million people in the U.S. have pre-diabetes mellitus. About a third of them are going to progress to type 2 if this is not identified and if they do not do significant lifestyle changes, particularly with respect to weight, physical activity, and diet. And what's probably even scarier, we know that once you have diabetes mellitus, your risk for heart attack and stroke exponentially increase. More and more research now is showing that even individuals with pre-diabetes mellitus have about a 50% increased risk for heart disease and stroke compared to individuals with normal fasting glucose and normal hemoglobin A1C values, even though that pre-diabetic patient has not yet met the criteria for diabetes mellitus. So important to screen, important to intervene on these individuals. We're going to get into some of the treatment of both type 1 and type 2. Let's talk about non-pharmacologic treatment of type 2. What are some of those lifestyle interventions that individuals should be doing who've been already diagnosed with type 2 diabetes or are found to be pre-diabetic? Number one, they need to be eating consistent carbohydrate and spacing their meals out. They shouldn't be binge eating. They shouldn't be sitting down and suddenly in one sitting taking in large amounts of carbohydrate. Carbohydrate should be spaced over the day. Individuals need to lower their overall fat and calorie intake. Individuals need to achieve some moderate degree of weight loss. A good goal is 5 to 7%. And individuals need to increase their physical activity. Another good goal would be 20 minutes of good aerobic activity. And walking is considered to be good aerobic activity. 20 minutes of walking 5 times a week. So spacing your meals, consistent carbohydrate intake, lowering fat and calorie intake, 5 to 7% of weight loss, and increasing physical activity. Partake in these activities, and individuals with pre-diabetes can minimize their risk of moving on, and individuals with type 2 diabetes can actually improve their parameters and minimize their risk of vascular pathology. So it's all about optimizing blood glucose levels, it's all about optimizing blood lipid levels, and it's all about controlling blood pressure. And all of these lifestyle activities are definitely known to improve blood glucose, lipid panels, and blood pressure. Okay, insulin action, just a wee bit of biochemistry here. Insulin is a protein. Insulin is going to act on certain cells and bind to a receptor known as the insulin receptor. Once insulin binds that receptor, a cascade of events happens within the cell, which is going to lead to the activation of certain genes on DNA. Remember, we looked at this already in the Unit 4 endocrine unit. We said a lot of these hormones activate critical genes on DNA. It's the same thing with insulin. It does it indirectly. Insulin never gets into the cell. Insulin acts at the cell membrane, and then by binding on that insulin receptor, the signal is brought into the cell to begin to activate pathways that are going to lead to all those anabolic effects. Those anabolic effects occur due to the activation of critical genes on DNA. Another extremely important mechanism of insulin is when insulin binds that insulin receptor, the cell signaling pathway is going to move a transporter protein called GLUT4 from the cell cytoplasm to the cell membrane. And that GLUT4 transporter protein is what's going to aid the movement of glucose into the cell, particularly liver, fat, and muscle. In order to get glucose into a liver cell, fat cells, or muscle cells, you require insulin. And what insulin does, insulin in and of itself does not move the glucose. The action of insulin is to move that transporter protein, GLUT4, from the cytoplasm and onto the cell membrane. Remember, glucose is a very polar molecule. It can't get through that phospholipid layer of the cell membrane. It requires GLUT4 to move, particularly liver, fat, and muscle cells. And when we talk about insulin resistance, what we're saying is insulin resistance at a chemical level is insulin is having difficulty binding onto the receptor, and once bound onto the receptor, these cell signaling messages are less effective. And when those messages are less effective, glucose can't move into the cell, and thus the individual develops hyperglycemia. So that's type 2 diabetes, right? Insulin resistance. Type 1 diabetes is the insulin is just not there. The individual is not making insulin. There's no insulin to bind to that insulin receptor. Let's look really quickly here at how we release insulin. So in the middle of the graphic here, we have a cell, and that is a beta islet cell. That beta islet cell in the pancreas senses glucose, senses hyperglycemia. The sugar will move into the beta islet cell. It uses a different type of transporter protein. It uses a protein called GLUT2. That GLUT2 is independent of insulin. So what does that mean? We can move sugar into a beta islet cell without insulin, okay? That sugar moves into the beta islet cell, and then that sugar is broken down for energy. ATP stores build up in the beta islet cell, and then ATP binds an ion channel called SUR1. Some people call it SURI, S-U-R-I. Technically, it's SUR1. ATP binds that ion channel, that is the potassium ion channel. It closes the potassium ion channel while simultaneously opening up a different calcium ion channel. When that calcium ion channel opens, it results in the degranulation of those vesicles which have already stored those insulin molecules, okay? So it's a little bit complex, but to summarize it up really quickly, in order to release insulin, first off, the pancreatic beta islet cells have to make it, have to synthesize it, and store it in the vesicles. So insulin sitting in those vesicles, waiting to be released. But in order to be released, the islet cell has to sense glucose. Glucose has to be metabolized into ATP. Potassium channels need to block. Calcium channels need to open up, and then the insulin gets released. And a lot of the pharmacology in managing type 2 diabetes is to try to get the individual to release more insulin. And we're going to look at that. In fact, you can see a couple of different drugs, sulfonylureas, maglitide, diazoxide. You can see that some of those drugs used for treating type 2 diabetes has a direct effect on that potassium ion channel, affecting that potassium ion channel such that the type 2 diabetic will release more insulin. So here's a question for you. Do you think that those drugs would be effective in an individual with type 1 diabetes mellitus? And you're thinking and you say, no, of course not. And of course, you're right. And the reason is the type 1 diabetic has destroyed beta islet cells. They have no ability to synthesize, produce, and release insulin. So some of those drugs that we use for treating type 2 diabetes would have absolutely no effect on a person with type 1 diabetes mellitus. Okay, whether you have type 1 or whether you have type 2, it's both going to lead to hyperglycemia. So again, normal blood glucose ranges between 60 and 120. So there's an individual with a glucometer and they're rating 264. So let me pose this question to you. If you did a random blood glucose level on a person and you found the blood glucose level was 264, do you have enough criteria there to say that they have diabetes mellitus? The answer should be yes, right? Because what is the random blood glucose, right? Number 6.5, 126, and 200. So yes, random blood glucose level over 200, we can say this individual has diabetes mellitus. Okay, hyperglycemia. We talked about this already. Symptoms of hyperglycemia: polyuria, polyphagia, polydipsia, fatigue, very hungry. Other things that we're going to talk about is the effect of hyperglycemia on skin and the effect of hyperglycemia in impairing tissue healing, particularly injuries to skin. And as hyperglycemia worsens, these symptoms develop. So you take an individual manifesting these symptoms who now show elevated hemoglobin A1C levels and elevated blood glucose levels, either as a fasting or a random, and now you can make that diagnosis of diabetes mellitus. And then you got to take it one step further and determine, is it type 1 or is it type 2? We should probably talk about hypoglycemia really quickly. The brain, the central nervous system, only utilizes glucose. And when glucose levels drop, neurons don't like that. So hypoglycemia, as you know, can lead to marked changes in mental status, including coma, and can lead to hypoglycemic seizures. So our brain needs a constant and steady supply of glucose. Again, remember the roles of insulin and glucagon. If you're not eating and your blood glucose levels start falling and your brain is screaming for glucose, glucagon is going to be released by those alpha cells of the pancreas and raise the blood sugar. Glucose can get into the brain in a non-insulin dependent process. So remember, we need insulin and GLUT4 to get glucose into fat, muscle, and liver. Glucose can enter a pancreatic beta islet cell without insulin. It does it through GLUT2. Glucose can get into brain in a similar fashion. It uses a transporter protein similar to GLUT2, and that transporter protein does not need insulin. So we'll talk a little bit more about hypoglycemia as we move on here, and I will pose some case scenarios for you to talk about experiences that you may have had with individuals who developed hypoglycemia as a complication of insulin therapy. Remember, insulin lowers blood glucose levels. Give an individual too much insulin, you're going to lower their blood glucose levels, and you can precipitate hypoglycemic events, including mental status changes, coma, and seizures. Okay, a little bit more biochemistry. What is it about sugar damaging blood vessels? Remember, I mentioned this early in the unit. I talked about an AGE, an advanced glycation end product, and these AGEs being a source of inducing vascular inflammation. Remember, vascular inflammation is part of that plaquing or of that atherosclerotic process. So what is an AGE? Very simply, an AGE is glucose binding to some type of nitrogen-containing protein on a blood vessel. And you can see all the chemical reactions going on in there. I'm not going to hold you to that. But if you take an individual who's living with persistently elevated hyperglycemia, some of that glucose is going to start reacting with nitrogen bases found on proteins on the blood vessels. And when that nitrogen base binds to the carbohydrate, you are going to develop insoluble chemical products which are collectively known as AGEs. FFI, CML, CEL. You can see a number of these different AGEs have been identified, and these AGEs are destructive to vascular cells. They act as inflammatory mediators, and they can start initiating and perpetuating the process of vascular inflammation, which plays an important role in atherosclerosis. So diabetes is a vascular disease due to the effect of these AGEs on the blood vessels. And remember, these AGEs can affect both small vessels, microvasculature, and the large blood vessels, the macrovasculature. And again, here's this glycosylation reactions, the carbohydrate reacting with the nitrogen produces the AGEs, and here I'm showing you two different types of AGEs. If you look in the book, they talk about hexosamine as being another important AGE which gets produced due to persistent hyperglycemia. All right, enough biochemistry for you guys. What is hemoglobin A1C? Hemoglobin A1C, some people call it sweet hemoglobin. It's hemoglobin which has been bound to glucose. We're going to talk in a lot more detail about hemoglobin when we get into the hematology unit and talk about red blood cells, but you're familiar with hemoglobin. Hemoglobin is the protein in a red blood cell which binds and carries oxygen. Well, hemoglobin, like every other protein, has nitrogen bases, and glucose can bind to those nitrogen bases, so we can get a state of glucose being bound to hemoglobin, and that is referred to as hemoglobin A1C. Hemoglobin A1C biochemically is a type of AGE, advanced glycation end product. Here I use a different abbreviation. I call it an AGEP. Same thing, whether you call it AGE, AGEP. It's a glycation product or a carbohydrate bound a nitrogenous base. Now, hemoglobin A1C is not pathologic. Hemoglobin A1C still works. It still carries hemoglobin, but we can use hemoglobin A1C as a measure of how severely hyperglycemic an individual has been and how long that individual has been hyperglycemic. So getting a hemoglobin A1C level, what we're actually doing is we're getting a biomarker. We're looking at something which we can use to help us make that diagnosis of diabetes mellitus. Okay? And if you look at A1C levels, and this has been kind of worked out fairly nicely, you can look at an individual's A1C level, and based on their A1C level, you can get an idea of what has been their average blood sugar. So the higher their blood sugar, the more sugar they're available to react with hemoglobin, therefore you make more A1C. And you will use this, and I'm sure a lot of you have been using this, looking at A1C levels, not only to diagnose diabetes mellitus, but also to judge your patient's compliance with their treatment of diabetes. Because if you make a diagnosis of an individual, say with type 2 diabetes, and they're presenting A1C level as 8%, when you start managing them both in terms of lifestyle changes and pharmacology, you want to see those A1C levels coming down, right? You get an individual who presents to you with an A1C level of 8%, you start treating them, they come back and see you in 6 months, and now their A1C level is 9%, you know that something's going on, and what might be going on is a failure to be compliant with the therapy that you're trying to do for them. So very important to be following A1C levels, and now you know, at least from a biochemical standpoint, what is hemoglobin A1C. Hemoglobin A1C is not pathologic. It's sweet hemoglobin, if you will, hemoglobin bound to glucose, but it's still functional. It still carries oxygen, and it still does its primary role. Now, remember, whether it's type 1 or type 2, hyperglycemia can lead to irreversible vascular damage, and that vascular damage is what leads to damage of the retina, damage of the lens of the eye, damage of the kidneys, coronary artery disease, peripheral vascular disease, neuropathy, which includes both peripheral nerves and autonomic nerves, and an increased risk of infection. So, very important. Doesn't matter what form of diabetes mellitus we're talking about, 1 or 2, the end result of vascular pathology is damage to the retina, damage to the lens, damage to the kidneys, damage to coronary arteries, as well as cerebral arteries. I didn't put that in there. You probably should add that in there. Cerebral arteries. Damage to peripheral vessels, damage to neurons, and increasing the risk of infection, particularly due to skin breakdown. All right, so a quick review here. How you should be able, at this point, be able to tell me how is diabetes mellitus diagnosed. You should be able to tell me about the symptoms of hyperglycemia. You should be able to talk to me about laboratory evaluations. What's the role of blood glucose and what's the role of hemoglobin A1C in making that diagnosis. Glucosuria, sugar in the urine, is a finding of diabetes mellitus, but it's not diagnostic of diabetes mellitus because there's other things that can lead to sugar in the urine, okay? So while many people with diabetes mellitus will have sugar in their urine, that in and of itself is not diagnostic of diabetes mellitus because other things can do that. And then you should be able to talk to me about the differences between type 1 versus type 2 in terms of age of presentation. Type 1 diabetic typically is losing weight. A type 2 diabetic is typically gaining weight. And then you should tell me about insulin levels and autoantibody levels. What do insulin and autoantibody levels look like in a type 1 versus a type 2 patient. Okay? There's a quick review for you. Now let's move on. Let's talk a little bit of history here. It wasn't too long ago that people with type 1 diabetes were being treated with animal insulin products, particularly pig insulin, porcine, and cow insulin, bovine. Diabetes mellitus, type 1 diabetes mellitus has been around for a long time, and that used to be a lethal disease. You develop diabetes and you wouldn't live very long. Initially, back in the early 1900s, people started to recognize the role of the pancreas in controlling blood sugar, and very early stages of insulin management and diabetes treatment involved injecting individuals with crude extracts of animal pancreas, and they would be found to live a little bit longer. They develop all kinds of complications in terms of infections and abscesses from injecting non-sterile products into themselves, but it prolonged their life for a short period of time. Somewhere in the 1960s, 1970s, insulin began a more purified sterile extraction of insulin was being done from animal pancreas, and therefore we had these pharmaceutical products primarily made by Eli Lilly of animal insulin, either cow or pig insulin. And I went to medical school between 82 and 86. I did my residency between 86 and 89, and I still quite vividly remember treating kids with type 1 diabetes with both cow and pig insulin products. Somewhere in the mid-80s, we started the first use of synthetic human insulin. So we're going to look at how did we get human insulin, because right now we're no longer using animal insulin, we're using human forms of insulin. And again, remember, talked about my science fiction book where we were taking growth hormone out of people. We don't do that with human insulin. We don't farm humans and suck the insulin out of them and inject it into somebody else. We're using microorganisms like E. coli to synthesize these human insulins. We'll look at this as we move on here. So three pictures here that I found on the internet. So there is a first picture, early 1900s, that really crude insulin non-sterile product that was being used. And then something called Ilatin from the Lilly company, a little bit more purified extract of the animal pancreas. And then eventually we had regular and NPH insulin, sterile insulin products, but that insulin was either coming from cows or pigs. And if you look at this here just really quickly, why is it that cow and pig insulin can work in humans? Cow and pig insulin can work in humans because when you look at the structure of the insulin, particularly at the components of the amino acid chains, you see that there's very, very few variations between human, pork, and beef insulin. And again, nothing for you to memorize. Again, if you want to put this in your head and look smart at a cocktail party, feel free to do so. But it's that very, very close similarity between these three species, between the insulins of these three species, which allowed people to treat humans with animal insulin. Now, there is some variation. So it was recognized as a foreign protein. So what eventually happened to individuals who were injecting beef and cow insulin? Yeah, they would develop antibodies against it. So at a point in their life, they would become resistant to the animal insulin due to the development of antibodies. One thing that I remember that they would do with some of these kids to try to minimize resistance is they would do pig insulin and then beef insulin. And they'd go so many months on one and then so many months on another as an attempt to try to trick the immune system. It worked somewhat, but eventually all these people developed autoantibody against the insulin, rendering it less and less effective. So Humulin was the first synthetic form of human insulin, and that synthetic insulin was made in E. coli, again, the Lilly company being at the forefront of insulin synthesis. Explain this really, really briefly. What do you do? There's a gene for insulin, right? Insulin's a protein. All proteins have a specific gene. So you isolate that gene. You transfer that gene into the microorganism. You get that microorganism expressing that gene. And when that microorganism expresses the gene, they build the protein. So E. coli and other microorganisms have been, through genetic engineering, they have been taught, if you will, to synthesize human insulin. You can look at that, you can put that URL website in, and you can look a little closer in terms of how human insulin is made with bacteria. So the first human insulin product was called Humulin, and that was human insulin, also referred to as regular insulin. Now what we have are pharmaceutical analogs. What does that mean? It's human insulin, but something about the insulin has been changed. The amino acid sequence has been changed. Fatty acids have been conjugated to the insulin. Additional amino acids have been made to the insulin. So you've heard of some of these insulin Lispro. They've substituted lysine and proline. Insulin aspart. They've substituted aspartame. Insulin glargine. They've added 2 arginine molecules to it. Dedimer insulin. They've added a long fatty acid tail to it. So as we move on here and learn more about insulin, we're going to look in a little bit more detail in terms of what are the primary, what I call the big 8, what are the 8 insulin analogs that we have on the market right now, which are primarily being used in the United States. So it's human insulin, but pharmaceutical changes have been made to that original Humulin insulin to alter the molecule. Pharmaceutical insulins now either act very quickly for a short period of time, or they have a long duration of action. And here are what I'll call these the big 8. These are kind of like the 8 insulin products that are most commonly used in the US market right now. 4 of them are rapid acting: Humalog, Novolog, Aprida, and the newest to the market is something called Fiasp. These are all rapid acting insulins. You inject it, they start to show effect within 30 minutes, and they have a duration of effect for about 2 hours. These are the type of insulins that a type 1 diabetic is going to inject before eating a meal, or if they're found to suddenly be very hyperglycemic and you want to lower that blood sugar quickly, you got to use a rapid-acting insulin. Once a day, long-acting insulins mimic the pancreas's basal release of insulin. So type 1 diabetic individuals are using both a rapid-acting and a long-acting insulin. Now a number of type 2 diabetic individuals are also using just a long-acting product. Something that injected once gives them greater than 12 and as long as 24 hours duration of effect, mimicking the basal dosing, right? 4 of them on the market: Lantus, Levemir, Toujeo, and Tresiba. And we'll look at how these insulins kind of vary. Rapid-acting insulins inject before meals or to correct an unexpected elevation of blood glucose. Again, the 4 on the market are Lispro, Aspart, Glulisine. Fiasp is interesting. It's Aspart insulin, but they've added some additional additives to it, which make it a little bit faster. In fact, Fiasp is probably the fastest acting insulin that's on the market right now. So where Lispro and Aspart come on in about 15 to 30 minutes, Glulisine and Fiasp, even faster, come on under 15 minutes. Is that going to be beneficial in the long run? You know, we're going to see. Future studies are going to show us what's the real utility of Fiasp having this insulin, which acts just a little bit faster than Novolog or Humalog, Lispro, and Aspart. Nonetheless, all these 4 are considered to be rapid-acting insulins. Long-acting insulins now have a longer duration of effect, and they can be effective for up to 24 hours. Glargine, which is Lantus, Detamir, which is Levemir, and then the 2 newest long-acting insulins on the market, Toujeo and Tresiba, their kinetics are very similar to Glargine. What do I mean kinetics? Their duration of action. So here's an important point. It doesn't matter what type of insulin it is, they all do the same thing. They all hit the insulin receptor. They all induce DNA copying. They all move that GLUT4 transporter protein to the cell membrane. They all do the same thing. I call that pharmacodynamic, the mechanism of action. How long the product works, meaning how quick it comes on, and what's its duration of effect, I call that kinetics, pharmacokinetics. So all the insulins do the same mechanism. They have the same dynamics. They only differ in their kinetics. Very important pharmacology, some basic bread and butter pharmacology to understand. Mechanism versus duration of the mechanism. The insulins differ in the duration of their mechanisms. So here's an example. We take a type 1 diabetic who's going to go through a day, have 3 meals in the day. That individual is likely to inject a dose of rapid-acting insulin prior to each meal to cover the carbohydrate for that meal. And then they're also going to inject a one-time long-acting insulin to cover the basal insulin needed throughout the day. There's a lot of different ways to do these insulin regimens. The photo is showing you what's called the intensive insulin regimen. That's 3 shots of rapid-acting per day spaced with the meal, with 1 long-acting shot. Some type 2 diabetic patients only inject a basal insulin once a day. Some type 1 individuals actually do 4 insulin injections per day, particularly if they're eating an evening snack. And then some individuals with type 1 diabetes just put their insulin on a continuous acting pump. So the pump is continuously putting insulin into their body. When they need the bolus of the insulin, they program the pump to give them the bolus dose. Okay? So different insulin regimens vary based on whether you have type 1 versus type 2 and how we're trying to control your blood glucose and how much carbohydrate is being consumed during the course of the day. So here I've listed for you insulins which are on the market, both by trade name and their duration of action. So Humalog, Novolog, Aprida, and Fiasp are rapid acting, and Fiasp is considered to be the ultra fast. The additives that were put in Fiasp for vitamin B3 and arginine. So it's still aspart insulin, but with those additional additives, it acts a little bit quicker. Lantus and Toujeo are essentially the same thing. It's glargine insulin. Lantus comes as 100 units per ml, and Toujeo comes as 300 units per ml, but it's the same exact insulin. It's just different in terms of the concentrations. Levemir and Tresiba are the long-acting insulins which have been conjugated to a fatty acid. Levemir has been conjugated to myristic fatty acid, and Tresiba has been conjugated to hexadecanoic acid. The fatty acid conjugate gives it a longer duration of effect. The glargine conjugate, those two additional arginine molecules, also give insulin the long duration of effect. So Lantus, Toujeo, Levemir, Tresiba, all the long actings. NPH is still out there. It's an intermediate acting insulin used twice a day, not as commonly used. And the initial regular human insulins, Humulin and Novolin, are still out there as well. You still will see Humulin and Novolin being used, but quite honestly, at least what I see in our hospital, we've really changed to the analogs, the Humalog, Novolog, Aprida, Fiasp just hitting the market right now. Okay, so there's your insulins, and now you know a little bit about what they are and how they differ. Okay, how about type 2 diabetes? Do you still need to take insulin if you have type 2 diabetes? Not necessarily, okay? Remember, we need insulin to get glucose into liver fat and muscle. A type 2 diabetic is able to make insulin. They may not be making enough, and the insulin that they're making there might be some resistance to the insulin that they're making, so we're going to do something to help them out. Later in life, particularly if they've burned out pancreatic beta cells, then they may become dependent on insulin. But let's assume at the beginning of their disease, they don't need to inject insulin. So what do we do to manage type 2 insulin is we try, the best interventions are lifestyle, physical activity, weight loss, dietary management. The best interventions for type 2 diabetes, mellitus patients are lifestyle interventions. And when lifestyle interventions aren't working, then we can start looking at pharmacology and what is it that we do in terms of pharmacology to manage type 2 diabetes. Well, to understand type 2 diabetes a little bit better and understand why the drugs work, we have to talk about something called the ominous octet. And you'll find this on page 740, and I'm going to explain it to you in the next slide. Now, the ominous octet is being, updated to something called the egregious 11. I've looked closely at the ominous octet and the egregious 11, and for now, I'm sticking with the ominous octet because I think it makes a little bit more sense. I have not yet started teaching type 2 diabetes as the egregious 11. Starting to sound like a Quentin Tarantino movie here, right? So I'm going to start with the ominous octet. So let's go to the next slide. Here's the ominous octet. The ominous octet looks at different mechanisms that lead to hyperglycemia. And in a type 2 diabetic, all or a combination of these mechanisms is enhancing the individual's hyperglycemia. And as we move around the ominous octet, we're going to start up by beta islet cell. And then we're going to kind of go around in a clockwise fashion. Problems that we see in type 2 diabetes. Their beta cells don't work as well as they should. So they're not making enough insulin. When you don't make enough insulin, your blood sugars go up. Type 2 diabetes have a decrease in the amount of a hormone referred to as an incretin. Incretins enhance the activity of insulin. Incretins enhance the release of insulin. If your incretins aren't working, and I'll explain incretins in a minute here, if your incretins aren't working, your blood sugar goes up. Type 2 diabetes have increase in fat deposition. Increase in fat deposition makes your blood glucose go up. In type 2 diabetes, you're reabsorbing sugar out of your kidney. When you reabsorb sugar out of your kidney, your blood sugar goes up. In type 2 diabetes, they have decreased uptake of sugar into their muscles. If you can't get the sugar into the muscle, your blood glucose goes up. There is a chemical in the brain referred to as dopamine. Dopamine plays a role in regulation of blood glucose levels and insulin. When you deregulate dopamine, blood glucose goes up. Gluconeogenesis. Your liver converts glycogen to glucose and releases that glucose into the blood sugar. It releases that glucose into blood, elevating blood sugar levels. And remember the role of glucagon. What is it about glucagon? Glucagon acts on the liver to enhance that gluconeogenesis and release more glucose. In type 2 diabetes, they tend to have over-functioning alpha cells that are making too much glucagon. So you go around the Omnis octet and you can see, geez, there's a lot of different reasons why an individual with type 2 diabetes is developing hyperglycemia. And if we can get at these different individual mechanisms, we can improve hyperglycemia. So here's the octet in words. Pancreatic beta cells are making less insulin. Pancreatic alpha cells are making too much glucagon. Their muscles aren't taking glucose up. Their liver is making more glucose than is needed. The effect of incretin on the GI tract is diminished. Fat cells are increasing. Dopamine is not working within the brain. And the kidneys are reabsorbing more glucose than they should. All right? This is the ominous octet. And when we look at the pharmacology to treat type 2 diabetes, what we're trying to do is we're trying to minimize different parts of the ominous octet, so therefore they have less incidence of hyperglycemia. But again, I'm going to stress this over and over, and a lot of you guys already know this. The best interventions for type 2 diabetes are the lifestyle changes, right? Weight, diet, physical activity. You can throw all these drugs at individuals with type 2 diabetes, but if you don't want to change weight, diet, and make the physical activity changes, you're just chasing your tail and things are just getting worse, right? And you know all that. I'm kind of preaching to the choir on that one, I would imagine. Review one more time. The non-pharmacologic medical therapy for type 2 diabetes, consistent carbohydrate intake, spacing meals, modifying fat and calorie content, moderate weight loss, 5 to 7%, increasing physical activity. Another thing which is really important in type 2 diabetes is they should be monitoring their blood glucose with glucometers, because it has been shown when individuals are monitoring their blood glucose, they actually have better control of the blood glucose. So one other thing that we should add into non-pharmacologic treatment is to get individuals to daily monitor their blood glucose with glucometers. All right, so now let's just really quickly, let's look at some of the drugs and how do some of these drugs help type 2 diabetes. We said that one thing that's happening in the ominous octet is the liver is making too much glucagon. So metformin, a mechanism of action of metformin is to stop the liver from producing so much glucose. So when the liver produces less glucose, blood sugar levels fall. Metformin has a couple other mechanisms of action. Another important mechanism of action is that you'll burn fat with metformin, and when you burn fat, you lose some weight. So metformin has kind of like two helpful mechanisms for a type 2 diabetic. In addition to losing some weight, they'll make less glucose in their liver. And metformin right now, in terms of pharmacology, is considered the first-line drug treatment for type 2 diabetes. You get an individual at new onset type 2 diabetes, very likely that they're going to be going on metformin. These are the sulfonylurea drugs, and the two big ones on the market now are glyburide and glipizide. Those sulfonylurea drugs, remember, come back to that SURI channel, that potassium ion channel. What the sulfonylurea drugs do is they bind to that ion channel. By binding onto the ion channel, you get an increased release of insulin. So remember, one problem with type 2 diabetes is they may not be releasing enough insulin. This is one way to kind of force the beta islet cell to work harder and pump out more. The acute benefit is you get more insulin out and control your blood glucoses, but what's the long-term problem with this? Think about this for a second. What do you think is the long-term problem with giving type 2 diabetic patients these sulfonylurea drugs? Yeah, is you're overworking their beta islet cells, and eventually they may burn out. And a new thing, which shouldn't say new, but definitely within the last years, a focus on type 2 diabetes is to try to preserve the beta islet cells, not blow them out, right? Not burn them out. So glyburide and glipizide work by this mechanism of action. I think we mentioned this already in this narration, but let's do it again. Can you treat a type 1 diabetic patient with this drug class? Why or why not? You should be able to answer that, right? Okay. Incretins. I mentioned incretins. What are incretins? Incretins are proteins. Another term for these proteins is called a GLP-1, glucagon-like peptide. Glucagon-like peptide is another hormone, another protein hormone. This one is synthesized by the small intestine, and this protein hormone has some favorable effects in terms of controlling blood glucose. Number one, and maybe the most important effect of GLP-1 is GLP-1, or these incretins, will suppress the release of glucagon. Remember, glucagon is a hormone of the pancreatic alpha cells. Glucagon increases blood glucose levels. That's the last thing you want to do in a type 2 diabetic patient, right? Is further increase their blood glucose level. So you use an incretin to stop glucagon. And when you stop glucagon, you lower your blood sugars. These incretins do a couple of other things as well. They help control appetite. They slow gastric emptying. So when you slow gastric emptying, you don't get this sudden surge and bolus of pre-digested food into the small bowel. Remember, the small intestine is going to do chemical absorption and absorb the nutrients. So if you hold the stuff in the stomach a little bit longer, you'll get less likelihood to spike your blood glucose levels. And the incretins, or this GLP-1, also helps improve insulin release. So you get a number of different effects of these incretins, of this GLP-1 protein, which are beneficial to individuals with type 2 diabetes. Now, because this is a protein, like insulin is a protein, to treat an individual with an incretin, they have to inject it, right? Because these are proteins like insulin. So let's look at them. Here are some of the incretins that are on the U.S. market: Victoza, Tanzium, Trulicity. The newest one out there is Luxumia. These are all incretins. These are all GLP-1 analogs. So just like Lispro is an analog of human insulin, liraglutide is an analog of human GLP-1. And you can see here what are some of the positive effects that individuals with type 2 diabetes get from injecting the incretins. Some of these incretins are made that you inject it once a day. Some of these incretins, like Luxumia, are made that you can inject it once a week. Makes it a little bit more effective for compliance, right? So you can see what they're doing in terms of glycemic control. You can see some of the other positive effects that you get from the incretins, but there are some adverse problems with incretins. A lot of people who start these get nauseated, they vomit. There are some adverse effects that happen at the GI tract. You can get some injection reactions. Individuals who have had pancreatic problems in the past, particularly pancreatitis, should not be using these. And I believe one of them has been, there was one that was removed from the market because it showed an increased risk of thyroid cancers. I'm blanking out on which one that was. So you got to be a little bit careful with using them. Let's see, what else do you think might be problematic with these incretins? And it has nothing to do with pharmacology. Did you get that? Cost, right? They're pretty freaking expensive. Very expensive, particularly these newer ones, and particularly the ones that have come out in this once a week type injection. So there's a lot of cost, and you have an individual who is underinsured. It might be difficult to be able to get them some of these GLP-1 analogs. Now, we talked about the role of beta islet survival, and one thing that has been shown with these incretins is where the sulfonylureas burn out the beta islet cells. These incretins actually prolong survival of the beta islet cells. So the newer thinking in managing type 2 diabetes is use these drugs as opposed to the sulfonylureas, because you have that potential, you have that ability to improve the duration of survival of their beta islet cells. You don't want them to burn out. DPP-4 inhibitors, Januvia, Onglyza, some of the newer ones that are out there, these are drugs. They're not proteins. They're small molecule drugs. And what these drugs do is they inhibit the breakdown of your endogenous incretins, right? So we make GLP-1. GLP-1 has a finite duration of action. GLP-1 gets degraded by this enzyme called DPP-4. So one way that you get your incretin, your GLP, to work longer is by taking a DPP-4 inhibitor. And the first drug that came out on the market was Januvia, sitagliptin, and a number of them have come out since. And they're just extending the patient's own duration of action of their own incretins. Now you're thinking to yourself, oh, so do you use an analog insulin and a DPP-4 together? No, you don't do that. You never use the two simultaneously. It's one or the other. An advantage of the DPP-4 inhibitors is that they're pills. You can take them orally, a little bit less expensive than the more complex protein that you have to inject. But again, very favorable in terms of what these drugs can do in terms of glycemic control. So there's your incretins at the top, the injectable analog protein, and there's your DPP-4 inhibitor drugs at the bottom, the once-a-day drug, which helps prolong the individual's own incretins. Okay. Again, these are becoming these have become very important in the management of type 2 diabetes. And the last pharmacology, kind of like the last group of drugs that are out on the market are drugs that are called SGLT2 inhibitors. SGLT2 is a transporter protein found in the kidney. And what SGLT protein, the function of that protein is to take glucose out of the urine, filtrate, and bring it back into blood. We filter glucose, right? When we're making glucose, when we're making urine, we're filtering glucose out of our blood. But SGLT2 brings that glucose out of the filtrate and back into blood. We don't want to pee our glucose out. We want to hold on to glucose because it's a necessary nutrient. And for an individual who does not have diabetes, that's an important mechanism. But how about an individual with diabetes? We have an individual walking around with a blood sugar of 300. Do we want them to bring back more glucose out of their urine and filtrate into blood? No. It's okay for them to dump the glucose. So these SGLT2 inhibitor drugs block that protein, and as a result of blocking that protein, they spill more sugar into their urine. They develop profound glycosuria, glucose in the urine. I teach this to the pharmacology, to the PharmD students, and I say, it's kind of like they're peeing out maple syrup. Well, they're really not peeing maple syrup, but they're peeing out urine that has a pretty high concentration of glucose in it. So they're effective. They certainly help reduce blood glucose levels. They've also been shown to be effective in reducing blood pressure as well. So that's another extra added benefit. So Farxiga, if I'm saying that right, Farxiga and Invokana, a couple other ones are out on the market. These are the first two that came out. Canagliflozin. It keeps the urine aflozin, right? That's another way to remember these drugs, flozin. Right? You're just peeing out more sugar. By peeing out more sugar, you're reducing hyperglycemia. And as you can imagine, and I'm sure as you have seen, because I'm positive a lot of you have managed patients on these drugs, you know that an adverse complication of having all that sugar in the urine is that microorganisms love sugar. So increased risk of urinary tract infections, both bacterial and yeast infections. And it also enhances their amount of polyuria and dehydration because the more glucose you put in the urine, the more they're going to pee. So some beneficial effects to these drugs, but again, definitely some adverse effects with these drugs as well. Oh, wait, one more drug in here, Precoce and Glycet. These are drugs that you can take when you're eating the carbohydrate. So you're eating the carbohydrate, you take this drug, and what this drug does is this drug blocks the enzymes in the GI tract responsible for breaking down the carbohydrate, particularly that amylase enzyme. So if you block that amylase enzyme, you can ingest the carbohydrate, but you won't absorb the carbohydrate, right? You can have your carbohydrate and not absorb all of it. And that might be a way to minimize postprandial or after eating blood glucose spikes. Well, where does that carbohydrate go? If you ate the carbohydrate, but you're not absorbing the carbohydrate, something's got to happen to that carbohydrate. Yeah, it sits in the gut and bacteria start to act on it, and then the individual starts developing excessive amounts of gas and diarrhea because they're not absorbing that carbohydrate. So these are not considered to be good drugs at all. Very high incidence of adverse GI effects. I don't know about you, but I'm really not into having some socially inappropriate moment of flatulence and diarrhea because I was taking a Precoce or Glycet. So that's just me. You might be different. I don't know. But nonetheless, not the best drugs for treating type 2 diabetes, but they're out there. Okay, we're getting close to wrapping up here. Now let's just really quickly just talk about the clinical pathology of diabetes mellitus. Remember that the adverse effects, the long-term vascular effects of diabetes mellitus are going to be there whether you've got type 1 or type 2. I'm just going to use type 2 and my friend your Homer Simpson as the example. So remember, persistent hyperglycemia is going to lead to skin pathology in the form of dry skin, breakdown of skin, increased risk of skin infection. It's going to have adverse effects on peripheral and central arteries, increasing plaquing in those arteries. It's going to lead to damage to peripheral nerves, leading to peripheral neuropathies. Most individuals with type 2 diabetes who manifest peripheral neuropathies manifest that in the lower extremities, and they manifest burning, tingling, numb paresthesia type pains. Increased risk of stroke in the brain, increased risk of retinal damage and cataracts in the eyes, increased risk of gingivitis, dental caries, increased cardiovascular risk, increased risk of myocardial infarction, heart attack. On the GI tract, one of the problems that you see with type 2 diabetes is they develop gastroparesis and impaired peristalsis as a result of autonomic neuropathy, so bloating, nausea, vomiting, constipation. We know that diabetic individuals eventually develop end-stage renal disease if the diabetes can't be managed. One of the most common causes of individuals going into renal failure and requiring hemodialysis in the U.S. is diabetic nephropathy. Genital urinary, particularly in males, erectile dysfunction. You think of it. How does a male get an erection? It's through increased blood supply, right, to the smooth muscle. If that blood ain't getting to the smooth muscle because of vascular disease, they're going to develop erectile dysfunction and impotence. And then we've all seen this, the effect of diabetes mellitus on the lower extremities and feet. You get these ischemic ulcers, and those ischemic ulcers can be extremely devastating in terms of secondary bacterial infection. So some of this stuff, retinopathy, nephropathy, myocardial infarction, stroke, we're going to get to all that in detail. So just hold on. I'm just kind of showing that at a high level now, but once we get into some of the more specific units, then we will really talk in more detail about atherosclerosis and stroke and diabetic nephropathy, etc. So just kind of showing this to you now at a higher, 2,000, 20,000 foot view, or whatever you want to call it, right? But again, pathologic, you can see pathologic damage to blood vessels is going to lead to multiple end organ failures. I have posted a really nice PDF file for you that comes out of the state of Wisconsin. It's called the Wisconsin Essential Diabetes Mellitus Care Guidelines. It's set up in 14 sections. There's 268 pages. No, don't read all 268 pages, but this is really nice. It covers everything you want to know about diabetes mellitus. I put that up there for your information. It's a really nice reference. My guess is this will probably be updated within the next couple of years as American Diabetic Association does their updates. You'll see updates being made to this. But what's nice about this is it's all there, everything in one huge PDF file, but everything you want to know about diabetes mellitus is there. So, keep that in your record banks and refer to that if you need to be looking at anything more specific related to diabetes. Here is one of the charts that you see in the Essential Care Guidelines, and it takes all those different body areas. It talks about the different complications, and then it kind of shows you, how frequently should you be monitoring your patients for these different disorders, whether they're type 1 diabetes or type 2 diabetes. So again, understand all the different pathologies that can happen, but I mean, this chart ain't here for you to memorize this chart. It's for a reference, so that when you are working in that clinic and you are seeing a new onset type 2 diabetic patient, or you're seeing a person who's now had type 2 diabetes and being treated for the last 3 years, this kind of gives you some guidelines and some clues in terms of what you should be looking at in their clinic visits and how often should you be screening them for certain types of pathologies. So again, that's a really nice reference to have. Let me just make a couple comments about some of these. Let's talk about diabetic foot ulcers. I'm sure a number of you have seen people with this. The diabetic foot ulcer starts as a sensory neuropathy. So remember, a lot of individuals with diabetes develop neuropathies, particularly a sensory neuropathy. So they develop numbness, tingling, and pain, particularly in the lower extremities and feet. And then they become unaware of localized trauma. Become unaware of localized trauma allows the initial skin breakdown to progress. And a combination of ischemic injury due to vascular disease and bacterial colonization leads to these what can be very profound foot ulcers. So here's a case. You have a 47-year-old male. He's had 10 years of being type 2 diabetic. He's very non-compliant. He still smokes. He hasn't had a clinic visit for 18 months. That's just a nightmare, right? You got type 2 diabetes, you're not being compliant, you're smoking, and you're not getting, evaluated. And now he comes into your clinic with this photo. He's got a fever, he's tachycardic, he's hypertensive, he's got diffuse paresthesias and numbness of the feet and toes. He's unaware that he's had an ulcer on the sole of his foot, and now this ulcer has become purulent, tender, and erythematous. So again, you can see the combination of ischemia, trauma, bacterial colonization can lead to these very profound, ugly, high-risk diabetic foot ulcers. And some of them remain superficial, where good localized care can be done. Some of them get pretty deep, can lead to sepsis, can lead to amputation. I'll have a Blackboard discussion thread that people can get into and talk about experiences that you may have seen with respect to diabetic foot ulcers, but they certainly can be extremely nasty. Diabetic neuropathy, so we're talking about peripheral nerves. A lot of diabetic individuals develop both autonomic and sensory neuropathy. So the sensory component is where they feel that numbness, tingling in the feet, toes, extremities. The autonomic neuropathy that they can develop may adversely affect the GI tract, meaning they get bloating, constipation, can adversely affect the genital urinary tract where they get urinary retention, can adversely affect the heart where they get swings of tachycardia or hypertension. So poor glucose control damages blood vessels and damages peripheral nerves. And the damage done to the peripheral nerves can manifest as either an autonomic or a sensory effect. And the sensory effect can be pretty painful. And I'm sure you've seen a lot of individuals with very painful diabetic neuropathy affecting their legs and feet. So there's a number of different drugs that are used to manage their pain. Cymbalta duloxetine is an antidepressant that has analgesic properties. Pregabalin Lyrica is an anticonvulsant that has analgesic properties. Opioid drugs can treat their pain. Maybe the newest opioid drug on the market is a drug called tapentadol. And then there's some topical creams, capsaicin creams, lidocaine patches can manage their pain. A very important thing to realize, and a lot of people don't understand this, and I'm going to say this just to be sure that everybody realizes this. When you put a diabetic patient on Cymbalta or Lyrica or tapentadol or Tegretol, and you're using that to treat their diabetic neuropathy, all that you're accomplishing is you're minimizing their symptoms. Those drugs have no effect on their underlying diabetes. Those drugs have no effect on managing hyperglycemia. They are solely being used to manage the pain and the discomfort of the neuropathy. Okay, it's a very important point to understand. Leading cause of blindness in the United States is diabetic retinopathy. I don't know a whole lot about diabetic retinopathy, but the one thing that I will say is all diabetic patients need frequent visits with the ophthalmologist, dilation of the pupils, and close look at the retina. And there's a lot of different types of surgical and laser and even now intraocular injections that can be done to help minimize diabetic retinopathy. But the real thing is glycemic control. Control your diabetes, because if you get to the point where you're having retinal hemorrhaging, it's too late. It's too late by then. You want these individuals being compliant to the lifestyle changes, to the pharmacotherapy that you're providing them, so you can minimize these delayed long-term pathologies like diabetic retinopathy. And you see a normal retina at the top left there, and then you see two examples of what diabetic retinopathy looks like, particularly the acute and the chronic hemorrhage which is happening on the retina. In terms of actual glycemic control, how do you pick the drugs? I showed you the drugs, and I showed you where the drug classes work with respect to the ominous octet. I am going to leave your pharmacology class to teach you how do you start the drug and how do you advance the drug. So again, number one in terms of glycemic control for the diabetic patient are the lifestyle changes. And then depending on their A1C level, you start to pick your initial therapy and add your therapy. And your goal is to try to get these individuals to a hemoglobin A1C level at least less than 7.5, ideally to 7. Okay? And it's called step therapy. You can pick one drug, two drugs, three drugs, multiple drugs. When multiple drugs are failing on the type 2 diabetic, you can add insulin therapy onto it. And usually the insulin which is added is one of those long-acting insulin like Mellitus or Toujeo, right? So again, there's a lot of pharmacology here, and I hope in a future pharmacology class, and certainly in your clinical rotations and working with diabetic patients, you'll start to get a feeling in terms of how do you initiate the therapy and how do you step up the therapy. I have given you what the drug classes look like and what those drug classes are doing in terms of glycemic control. As you get to this upcoming quiz and exam for this unit, be sure that you understand the differences between type 1 and type 2 in terms of the presentations, the pathophysiology. Be aware that obesity, diet, and sedentary lifestyle is going to complicate both of them, but particularly type 2. Recognize the acute symptoms of hyperglycemia and understand the long-term complications of type 1 and type 2 diabetes. Renal failure, cardiovascular disease, peripheral vascular disease, stroke, peripheral neuropathy being some of the more severe complications of diabetes. Add into that foot ulcers and neuropathy, autonomic neuropathy, and you can see that this can be a very, very devastating disease, particularly in the non-compliant individual. But let's make Homer happy and woohoo, right? With proper management and lifestyle changes, the complications of diabetes mellitus can be avoided and reduced, particularly in individuals who are found to have diabetes mellitus. For all those individuals that you encounter that have prediabetes and have those risk factors, be sure that you're doing something in terms of lifestyle management, trying to avoid them from moving on into type 2 and trying to avoid them from developing the long-term complications of type 2. Okay, we're done. We're done at 2 hours and 5 minutes, so not too bad. I hope that was useful to you. I debated whether or not we should do an entire unit on diabetes, and the more that I revise this unit, the more I am confident that it was the right thing to do, is to spend an entire week on diabetes mellitus. So, okay, finish up the do your studying, finish up your discussion threads. You have a 10-point quiz on diabetes mellitus this week, which is due next Tuesday. And I will say au revoir. Geez, I can't talk anymore. I will say au revoir for now, and I will see you guys in the discussion threads. Thank you.